It's Kevin and Donna, and we are super excited for this episode of the Deprescribing Show. We've got all kinds of things going on with a particular case, and Donna and I
Mhm.
want to break it down into a few sections that'll hopefully be helpful for you. There are a few things that Donna and I have run into of recent that I think will be really interesting if you haven't seen them before. So stay tuned, get to hear about it a little more depth, and we'll see you in a couple seconds. Donna, how are you? We just got to
Right.
talk about being an empty nester. How is that feeling of moving your son out? That is super exciting.
Uh, it's it's a little bittersweet, I have to say. It seems a bit more final to me. It's not he's coming back from college. He's actually graduated and moved out. So,
Gosh, what
um,
a big step.
but not that far away. So I'll get to see him plenty.
I'll get to hear all about that, I'm sure, in my 2 and 4-year-olds at that stage of life. We can share stories back and forth on that one. So speaking of sharing stories kind of back and forth, Don and I were talking about two things we just wanted to plug, and we'll introduce this case. But some stories of just things we run into, like along the way. You just don't encounter a case like this, or you see a new patient that presents in a different way that you look up some additional material. And so please, if you're listening, all of those that are listening that I'm seeing you on the reader, tell Don and I like the things you've run into in your cases and the
Yeah,
little nuances, because that only helps all of us be better clinicians. So let me pull up
absolutely.
these slides, Donna, that you sent over my way. But if you want to start introducing, our case, that'd be amazing.
Yeah. So Our f the case that we're gonna actually be bringing up, if that is that the case you're talking about, Kevin? Okay, yeah. So we're actually talking about a, 35-year-old woman, so a little
Yep.
bit different than, the folks I typically see, so Kevin, I was so glad that you brought this forth, and, just has so many medical issues, and we're going to break down various medical issues as we go through. So you're going to see this case a few different times. But today we're going to be talking about cholesterol lowering. And part of her issue was that she had tried many different statins and she was probably on cholesterol medication because of many of the psychiatric type of meds that she's taking. So, probably looking at some metabolic issues that's causing the hypercholesterolemia, hypertension, and various issues that she has. But anyway, so we're looking at this case, and we know that she not everybody responds to statins for one thing, and we understand that. So she tried a few different ones, and now we just see a succession of things going on. I think what's really important to Kevin, like we talked about, is once you get the workhorse in place and you finally have something that's working,
Yep.
let's not try to keep everything going here. We got to remember to deprescribe once we finally find the sweet spot for the patient.
Right.
So I'd love to, if you want, we can go through some of the slides a little bit.
Do
And so this week we're just talking about more or less the cholesterol side of things, but we can also talk about some other issues. So just one part about the statins, and not that she's on any statins at this time, but we are talking about this, and I had a super interesting case this week, and I was talking to Kevin about it, in the importance of prescribing rosuvastatin appropriately, especially, and I'm looking more at older adults. This case is a 35-year-old, but anyone with poor kidney function, we really have to be vigilant about when we're looking at rosuvastatin. So even if somebody has a high cholesterol, we can only dose rosuvastatin up to 10 milligrams if their creatinine clearance is less than 30 milliliters per minute. And what they suggest in older adults is that you start off at 5 milligrams of rosuvastatin and only go to a max of 10 milligrams. So I had a really interesting case last week where we had somebody on 40 milligrams rosuvastatin, had some compromised kidney dysfunction, and was pretty close to that 30 cutoff. And she ended up having a lot of issues. worsening of her chronic kidney disease, and then also ended up with proteinuria and hematuria. So lots of issues that this person had. We got her down to 10 milligrams of rosuvastatin, and her numbers were so much better. So we have to optimize our meds, and sometimes that means reducing them, right? So that we are certain that we are really using the medicines as intended for the individual. And so hopefully she'll still continue with good results that she needed, but hopefully a safer dose for her.
No, that's perfect, Donna. I think that is so interesting when you and I talked about that, that I'd run into a case that I'd ran into this little nugget previously, but it's interesting as we continue to quote unquote practice medicine, that there's just so many updates and so many changes that previous practice, led us to 52% of individuals taking 20 or 40 milligrams of
Right.
rosuvastatin
Yeah.
inappropriately. More than half, were taking
Right.
and it almost seems accidental that we don't have, even more individuals that we would have ramped up to that
Mhm.
dose. And so,
Right.
some real curiosities are one, we started to see more and more issues related to simvastatin utilization. So we had a real
Mhm.
conversion that went, no,
Yes.
simvastatin's giving us issues. Let's switch to rosuvastatin, just
Mhm.
keep bumping up the dose and we'll get to our LDL goals. And
Yeah.
so that reminds me of the other nugget that Don and I just talked about is before the case and before today, I looked at a couple studies that were really diving into triglyceride management and lipid management. These
Mhm.
international studies that were kind of published out there, the recommendations for what labs should we be jumping into most particularly. And the one study, the US study, and the guideline in the United States is really honing in on still using traditional lipid panels. Reason why is cost. We're trying to decrease cost overall. The other two international panels already are recommending ApoB. So they're looking at using a different biomarker for us to be able to
Mhm.
know how well are we doing with managing our lipids. And so there's some really interesting also international flavors. You guys have probably already heard Don and I reference Australia
Mhm.
several times with the way that they go about, deprescribing and working with the clinical algorithms, et cetera.
Yeah.
But I think that's one really important thing for all of you young clinicians out there and older clinicians to be
Mhm.
really aware of is there's just so much information that keeps getting sent your way. And,
Yeah.
being active in these kind of journal club moments can be so helpful. Also
Right. Right.
back to Donna to
I love the education that happens too, because once you bring these ideas forth, um, and you get the team involved, so you have the attending and you have the nephrologist, and you really start looking at this and saying, "Hey, here's this information," and everyone's enlightened. And I have to say, being so enlightened, we've made a lot of rosuvastatin recommendations as of late in just 1 week's time, because you definitely see that 50% are being over prescribed. So, yep, 20s and 40 milligrams are often seen in our older adults, and it might not be appropriate. So,
yeah, it's
um,
you mentioned that. That reminds me of do you remember the tramadol codeine wave that happened to everybody out there? Yeah, when all of a sudden we were just like sending tramadol out the door and then went, wow, I guess there's a pharmacokinetic and pharmacogenetic
yeah,
factor inside of here we didn't recognize, and we
absolutely.
were prescribing to kids in the ER all the time
Yeah,
and been rather problematic. So
right.
definitely something to keep your eyes open to. And speaking of keeping your eyes open, for
Yeah,
everybody watching, don't worry. Don and I will break this case up from its complexity, and we'll just dive into certain aspects. But Don,
yes.
please take it away.
Yeah, so there's pages and pages of meds, so we can just count the polypharmacy. I think there's at least a minimum of 6 meds per page, and there's 4 pages of meds, so we're at 24 for 35-year-olds, so kind of
Yes.
blows your mind. But so you can see some of these things that are going on here, and, a lot of duplications are occurring too, multiple meds for multiple, reasons. With the whole metabolic syndrome between blood pressure issues, diabetes, type 2 diabetes, and cholesterol right here on this first page, you can see it all coming together. And then as you scroll through, you'll also see that there's a number of psychiatric meds. There's some thyroid issues too. We know that there's a link with thyroid and cholesterol too. So how's that for the patient? Is that an issue? But now we just start seeing some of the psychiatric meds, and some are being moved around a little bit, but there's a lot of issues with what's being prescribed here, what's working, what isn't working, and why are things just being continued. So then we have a whole bunch of gut health, right? So, kind of just, what's going on there with the patient, what isn't agreeing. And can see the fish oil here too. So, another thing that somebody's, trying to take care of, probably cholesterol wise, or, triglycerides, thinking it's heart healthy. So again, more issues. And then I think that there's some other things on the next page too. Not
Yep.
certain if they completely relate, but again, many other things that just don't make sense for our patient. So, so we can go back to that first slide again, and we're going to hone in on thinking about these cholesterol meds that the patient's using. So remember, tried many statins, unsuccessful. But she's also, remember that there's that fish oil. We don't really know the dose of it. We just know she's been taking it. So what's going on there, and what hasn't been successful? Trying to reduce her LDL. And Kevin, you might have to jump in here a little bit with some of the numbers of the LDL. I think you had it on your end.
LDL was last to 110 on our side was the most recent measurement after
Yeah,
some of the changes had been instituted, and there was
yeah.
a high level of success after the Repatha was added on board to be able to get those numbers to where they wanted it to be.
Yeah, so finally seeing the help with the Repatha. But then we can see the um um I'm sorry, Kevin, I'm barely seeing the drug.
SEPA.
Um yes.
Yep.
Yes, for CEPA. Thank you. And so with that, this is an omega-3 basically. And so
Yep.
we're adding on more omega-3s, your fish oil type things, and still there's no success. And she's taking this before the Repatha begins. So when we're looking at this, it's just like, okay, so that's not really working either, but she's still on it despite the fact that finally she's on the Repatha and finally having success with that. So why are we keeping on fish oil, and why are we keeping on the Vasepa? Like there's probably no need. So we can already deprescribe two meds because we know Repatha is actually working for her.
Mhm.
So we do have our successes finally, but let's make certain that we work through it and make certain that we're not keeping unnecessary, inappropriate meds that might still be pumping up that LDL and not helping.
Yeah, totally. I think that you just hit on a really interesting point there is without having the triglyceride levels in the previous triglyceride history, it's really interesting the addition of some of these fish oil and or fish oil derivatives on, how they're going to work in therapy. There's some really good studies like out of the University of Michigan related to the heart benefits of adding on an EPA like the Vasepa and some of the benefits they can have overall, along with the PSCK9s like the Repatha. But fascinatingly, it's really a lab chasing endeavor, when we get down to it with some of these things.
Mhm,
And so it's nice to see that we're looking at something right now that is related to the overall lipid panel, which was the major kind of component of concern, related to that use of hyperlipidemia in the family. And
mhm,
then moving back and saying, okay, if we have the lipids now under control or to a level that we would like them to be, what is the next, step with these triglycerides? And so my question is going to be back to you, Donna.
yeah,
How do we break it up? I think in general, like you go into pharmacy school, maybe get an opportunity to go and you do a lipid panel just based on this little machine that they bring in, you're doing your skills assessment, right? And so out of that, you get a number of numbers that pop out at you. And so
mhm,
now we have to
mhm,
do this interesting balancing act of how do we tease the
yeah,
LDL, HDL, triglycerides, total
mhm,
cholesterol in the
yeah,
direction you want? How do
yeah,
you work through with a student, physician,
yeah,
or patient on how to do that
yeah,
appropriately and what to
yeah.
target?
So we see a lot of cholesterol ratios now that come through onto the labs as well, which is the total cholesterol over the HDL.
Mhm.
So when we're looking at that ratio, if it's 4 or less, then we're okay with that. We're happy with that number, and of course, lower is better in that regard. It means that you have a higher HDL, and that's what we know. We know higher HDLs are better, and that's what we're trying to do with, a lot of these meds that we're using. Other things that we look at is we'll look at non-HDL. And so that's the total cholesterol subtracting the HDL number. As long as that is 130 or less, we're okay with that. We're like, all right, this works well. And we're fine with that. The other that I've recently been studying and have seen in studies is once you reach a an LDL of less than 50, that's like you want to start making some changes, especially in our older adults. It's too low from some of the studies, and I apologize, I don't remember exactly the studies that we were looking at off the top of my head,
Yep.
but there are some out there that say, you know what, once you hit less than 50, you don't need to be so aggressive. You don't have to be so intense. So sometimes we can back off, and that might mean um, healthier muscles for folks. Maybe they don't realize that they're weak. Maybe they don't realize that they're achy. Maybe they're just blaming age kind of thing. So that's a number that we're starting to look at a little bit more. And actually one of my students, who I do hope to have all my students who are presenting posters in another week down at ASCP, to be here and to present theirs, because it's great work that they've done. And one is this whole cholesterol debate that's out there. There's so many questions about it still. So that was a really neat finding, because we'll see total cholesterols of 70 or under 70 total cholesterols, and I'm just, it cannot be healthy. But I read some articles as low as you can go, and I'm just like, no, there's got to be a bottom here. There's got to be something where, like we talked about U curves, J curves and U curves, right? We did this before. Um, but so those are some other numbers. When we look at triglycerides, yes, over 150, you get a little bit like, okay, your triglycerides are elevated, but you really don't have to treat until you're around 500-ish and higher, 450, 500 in there. So if you have elevated triglycerides, yes, it's concerning. And yes, you should be, lifestyle changes and things such as that. But probably do not need to really treat aggressively unless that they're higher. The other thing is that if someone has low LDL, you could try a fish oil for them, but you got to keep looking at that LDL. If it's increasing, you don't want to continue a fish oil or an omega-3. You've got to be vigilant about follow up.
I think that's perfectly said. I mean, I love that you bring several of those topics up, and including some of the ratios that are so important for us to be able to look at, and the bottom. Like, we just
Mhm.
so often are chasing a number and pushing against the number until it becomes rather problematic. And I in my career, I've seen that most often in my type 2 diabetic patients or type 1
Mhm.
diabetic patients,
Yeah,
right? I mean, we just see it
yeah.
pushed so hard. And interestingly,
Mhm.
the other group that I've seen it is hypertension. We're always
Mhm.
chasing after that gold number, and then we are causing issues and falls. Well,
Yeah.
even though it's maybe a buried truth, I think we're going to start uncovering more and more things about how we've been pushing cholesterol too far and causing more issues than
Right.
we thought we were before, just like you mentioned at the beginning of the show with
Sure.
rosuvastatin being on board. I'm
Mhm.
going to show my screen here, Donna, so you can peek at
Mhm.
this guide. It'd be, I'm sure everybody watching will be like, why don't Kevin and Donna go over all the guidelines like before the show? Well, Kevin and Donna are super busy, so we're going to do it right here in front of you guys. Um, um, but here's a comparative study that was really looking at like the non-statin and the LDL-C goals. But there's
Mhm.
the three guidelines: the ESC, the AHA, and the CCS guidelines. And
Mhm.
interestingly, without everybody having to read through text, we really get to see that the PCSK9 inhibitors, which the Repatha is part of, those are going to be a next add-on, if
Mhm.
the statin goals are not being reached. And
Right.
interestingly, the other drug that I saw next to it was ezetimibe. And
Mhm.
I'm not seeing that prescribed as often, any longer. Like
Okay.
that does not seem to be in favor. And I'm seeing more
Yeah,
PCSK9s prescribed
absolutely.
instead. Do you have any thoughts on that, Donna?
Yeah, so it's funny because I agree, like, don't see it that often, but lately I've been seeing it again. I'm like, "Why? Why is this?" And, for some insurance companies, it is a step therapy to do the statin and the ezetimibe before you can move on to Repatha, for example. So sometimes we're seeing it because of insurance, and their step therapies. So I think that's more a driving factor, Kevin, than actual, outcomes, but you can use either or to start with. I do know that people who actually um, just can't um, tolerate statins. Um, I know some that do go right over to um, the uh, PCSK9s, and I just think that that's an issue, sometimes because we don't have a lot of information. It's typically, like you're saying, it's an add-on. So sometimes they might not be as effective. I think they are still effective, but I don't always know that they're always as effective as is thought of if you're switching it out.
Totally hear you. Yeah, and I think that for those of you that don't have the steel trap mind of Donna Bartlett, here are some of the scores or some of the levels that are being shot for with the ESC guidelines that they're looking at the LDLC, just incorporated here and one of these step therapy like next steps if the LDLC is still above the 55 milligrams per deciliter. So
Mhm.
there's their goal. Then when you go down to the AHA, you're seeing a very similar 55 milligrams per deciliter. But here is an interesting piece
Mhm.
with CCS. Now we get to pull into labs that some of us may have never seen. You get to see that there's an ApoB,
Mhm.
criteria here between or greater than or equal to zero point 0.7 to zero point 0.8. And you can see the non-HDLC that Donna had just mentioned. So there's some other great guidelines that if you're thinking, oh man, the only thing I have to go off of is just, these details or these clinical reports, there's some additional details that come out of other countries that can help break down those laboratory values for you and give you guideline recommendations on what do I do next, with those individual therapies. So I just wanted to bring that up for context
Excellent.
there. Cool.
Great
No, I think that
clarification on that.
with this study, I mean, and with this individual case, we'll go into more and more details with each one of these and start pulling up some algorithms for you guys to be able to peek at. But in general, Donna, what are your key takeaways with, and I'll pull up that patient case one last time for us to give
Mhm.
kind of a summarized key takeaways from this episode.
So if we're looking at the statins, just we have to be vigilant. We have to be thinking about what people are using for over the counters, fish oil, for example, and why they're doing that. Like I said before, a lot of duplications on things. We need to be thinking about um, what all their numbers are, what's their A1C, for example, even, and what is their blood pressure with these meds. There's a lot of psych meds, which I just think is overdone. And, if we're changing things around, maybe, Kevin, we might be able to reduce some of the metabolic syndrome that's being that's it, happening here with this patient as well.
Okay.
So I think that there's much to still look at. QTC prolongation is something too, that I love talking about that. Muscle relaxants that might not be appropriate. There's just so much happening with this patient.
Yeah, I think there's some really interesting things when you look at a patient that has, some chronic kidney disease related to, their medication utilization and some of the guideline recommendations on, yes, if you have chronic kidney disease, there's still a recommendation. Well, you also have a patient that's diabetes. Well, there's more recommendations for statin therapy, or cholesterol lowering therapies, I think in general. But here, the main takeaways that I really had related to this
Mhm.
overall patient is let's get some lab work back. Let's be able to see what are the triglycerides in general, and some
Exactly.
additional laboratory values for us to peek at. And then, as
Mhm.
Donna just mentioned, that I'll just re-highlight is the fact that sometimes you are going to encounter things that are duplicative therapies that don't even look like it off the beginning.
Right.
It's not literally one fish oil tablet and another fish oil tablet. It's
Mhm.
something that's hidden that is fish oil, it's just
Mhm.
a derivative of
Yep.
fish oil in the Pasipa, and having another fish oil right here, just being
Yep.
undefined in the
Yep.
OTC cabinet, that can cause additional problems for your patients that you may not have recognized initially. So there were
Mhm.
my big highlights related to the cholesterol elements, and the rest of
Yeah.
it, Don and I will have lots of tidbits when it comes to the
Mhm.
psych elements, the blood pressure control, the interactions that you're going to have with the thyroid medications, and so on and so forth.
Mhm.
So definitely tune in
Yeah.
there and bring your questions and thoughts along
Yeah.
the way.
Absolutely. Thanks,
Awesome. Well,
everyone. Thanks, Kevin.
all right, everybody have a great night. Talk to you soon. Bye bye.